Good evening, everyone. I am so excited to learn this evening from our amazing panelists. I just want to take a moment to introduce myself. I am Shea Rhodes. I am the director and the co-founder of the Institute to Address Commercial Sexual Exploitation, based out of Villanova's Law School, right outside of Philadelphia. I'm also really thrilled to be a member of the College of Physicians and a fellow in the college, based on all of the work that we have done here at the CSE Institute and our intersection with public health and our collaboration with the public health community as it relates to victims and survivors of systems of prostitution and sex trafficking. But one of the questions that I am consistently asked whenever I speak publicly and I get emails all the time are, what about labor trafficking? What's happening in our community regarding labor trafficking? And I always defer to our amazing partners at Justice at Work to answer those questions for me. But again, I'm really excited for this, conversation that we're going to have this evening and to listen to the presentation. So as we end Human Trafficking Awareness Month, January is Human Trafficking Awareness Month, I think it's awesome that we're talking about the intersection of labor trafficking. I mean, not awesome that it happens, but awesome that we're talking about it. The intersection of labor trafficking with healthcare providers and public health systems. With me for our important conversation tonight is Dr. Hanni, I'm going to say it wrong, but I'm going to get there, Stoklosa, and Phil DeCicco from Justice at Work. Phil DeCicco is the Interim Director of Operations and Compliance at Justice at Work. Many of you may know Justice's work formerly as Friends of Farm Workers. Throughout his time at Justice at Work, Philip has worked as a paralegal, an outreach coordinator, and administrative support staff. Previously, he has worked in a number of roles supporting immigrant and low-wage worker communities in Pennsylvania, including in refugee resettlement agencies, as a Spanish language legal interpreter, and in community project coordination. Phil has an MS in public policy and management from Carnegie Mellon's Heinz College. Dr. Hanni Stoklosa is the Chief Medical Officer of HEAL Trafficking and an emergency physician at Brigham and Women's Hospital, with appointments at Harvard Medical School and the Harvard Humanitarian Initiative. Dr. Stoklosa is internationally recognized expert, advocate, researcher, and speaker on the well-being of trafficking survivors in the U.S. and internationally through a public health lens. She's advised the United Nations International Organization for Migration, the U.S. Department of Health and Human Services, the Department of Labor, the Department of State, and the National Academy of Medicine on issues of human trafficking. She's testified as an expert witness multiple times before United States Congress. Moreover, she has conducted research on trafficking and persons facing the most significant social, economic, and health challenges in a diversity of settings. Among other accolades, she's been honored with the U.S. Department of Health and Human Services Office of Women's Health Emerging Leader Award and the Harvard Medical School Dean's Faculty Community Service Award. She's been named as an Aspen Health Innovator and National Academy of Medicine Emerging Leader. Her anti-trafficking work has been featured by the New York Times, National Public Radio, Fortune, Glamour, Canadian Broadcasting Corporation, Stat News, and Marketplace. She's published the first textbook addressing the public health response to trafficking. Human trafficking is a public health issue, a paradigm expansion in the United States. Justice at Work and HEAL Trafficking began their interdisciplinary collaboration in 2021 with the goal of bringing their legal and medical expertise and partnership to educate healthcare providers about labor trafficking, informing responses to labor trafficking in the healthcare space. Labor trafficking is often overlooked in the conversation about human trafficking. Spotlighting the amazing work that has been done is more important than ever, and I'm grateful to the College of Physicians for creating this opportunity. So I am just thrilled to have both Phil and Dr. Stoklosa here with us this evening. Everyone, please, I encourage you, I'm going to monitor the Q&A. If you have questions, please pop them in the Q&A box, not in the chat, but in the Q&A box, and that will focus my attention to look at them. Both of our presenters have encouraged me to ask you all that if you have questions as they come up in the flow of their presentation, you don't have to hold them to the end. So again, I'm super excited to learn from both of you this evening. Welcome, and I'm going to turn it over to you now.
Thanks so much, Shea. And I'm super excited to see folks from all over the country. Good afternoon, good evening. The sun has officially set here on the East Coast. And as Shea mentioned, we would love for this to be interactive. So we will be monitoring the chat and looking at your questions. Feel free to pipe in with clarifying questions as we go along. And I encourage you, as we're talking about labor trafficking and its intersection with healthcare and some of our research findings, to think about some things that surprise you, to think about how this may change the work that you do. I see that some folks are in a variety of different practices, whether it be law, whether it be public health, whether it be forensics nursing. So we have a lot of different professional expertise in the room. I wanted to kick it off by just sharing a little bit about my own journey to this collaboration. So I am an emergency physician and co-founder and now chief medical officer of HEAL Trafficking. And one of the things that struck me and continues to strike me within the anti-trafficking space is how little data that we have on labor trafficking to inform our practice. And there are a lot of reasons behind that. What was shocking to me is to notice the disparity, not just, oh, maybe there's less data because there's less people affected, but the information that we do have about prevalence indicates that labor trafficking is more common than sex trafficking. And what I realized is that there are historical reasons. There are reasons grounded in the way that media portrays trafficking. And I know Phil's going to get into that further. But I also have come across just this sense that we measure what we value, and we understand and study what we value, but we also understand and measure what is easier to measure. And so because of all these nested reasons, as a health practitioner who is desperately trying to understand what are the ways that labor trafficking victims are interfacing with our health systems, how do we best reach them? How do we best care for them? I found myself in a position of where is the data? Where can I find this data to help inform our practice? And rarely in healthcare do we look to the legal sector to try to get data. But in this case, through a collaboration with Justice at Work, we were able to realize that there was some health data in case files that could help inform healthcare's response to trafficking. So we're really excited to share this groundbreaking research with you. And I, as the clinician of the two of us, will do my best to also weave some of the clinical pieces and interpretations to the data as we get to that place. But just wanted to kick it off with a little bit of further background about the beginning of our relationship and collaboration. And to encourage you to think of questions and throw those questions at us. So without any further ado, I'm going to kick it over to Phil.
Thank you so much, Shea and Hanni, for those introductions. Pleasure to meet everyone this evening. My name is Philip DeCicco. Just quickly about Justice at Work before we head off into the presentation. We're a legal aid organization based out of Pennsylvania. We serve low-wage and immigrant workers across the state with a special focus on migrant and immigrant workers in low-wage industries such as agriculture, landscaping, and construction. The majority of our clients are Hispanic and Spanish speaking, and the bulk of our services are geared towards severe workplace exploitations, including labor trafficking and sex trafficking. So that is the lens that I will be presenting lots of this from. Super excited to have Hanni here to translate this into some of the more clinical terms for all of you. And really hope that this research ends up being as exciting for you all as it has been for me to uncover. So without further ado, we can get into it. If you go to the next slide, please. Just to give you all a quick roadmap of how the conversation will go today, we'll start with the little labor trafficking 101 definitions and key terms. Then Hanni will talk about the intersection of labor trafficking and the healthcare system based on the findings from this collaborative research that we've done. Then I'll go through some case studies to hopefully ground for you a little bit more what labor trafficking looks like in Pennsylvania and some of the ways we see our clients interfacing with the healthcare system, even in the midst of their trafficking experiences. We'll share with you some recommendations we have on how you as medical health professionals can be better advocates for survivors of labor trafficking in your day-to-day, and round it off with a few final thoughts and space for some Q&A. So labor trafficking 101. Before we talk about labor trafficking, I first want to take a step back and clarify a few terms that are often used interchangeably but mean somewhat different things. So you have human trafficking, and if you click next slide, human trafficking is an umbrella term that encompasses sex trafficking and labor trafficking. Before I go into the definition of labor trafficking, I want you to take a beat and think of the first thing that comes to mind when I say human trafficking. What is the scenario that comes to mind, the victim, what situation is elicited in your brain when I ask you to imagine what human trafficking is? Most likely, most of you are thinking of a female victim or a minor. They're probably not from the United States. The person or situation you're imagining probably involves them being kidnapped or tricked into joining or becoming complicit in some kind of criminal organization. They've probably been smuggled into the United States illegally, are likely, you imagine them being held somewhere against their will and being forced or manipulated into participating in the illicit sex trade. While this is an unfortunate reality of one of the things that constitutes human trafficking, this is characteristic and descriptive of sex trafficking, which is distinct from labor trafficking. And I wanted to drive this home a little bit. Most of the time when we talk about our responses to human trafficking and the toolkits we have to screen and address human trafficking, we're really talking about tools and screenings for sex trafficking specifically, something that models more the kind of situation I just described. In doing so, lots of our response toolkits and policies we have to address human trafficking leave labor trafficking out of the picture. So if labor trafficking is not the situation I just described, what is it? This is the definition from the Trafficking Victim Protection Act. Labor trafficking is a process of recruiting, harboring, transporting, providing, or obtaining someone through a means using force, fraud, or coercion for some end to exploit their labor, including involuntary servitude, peonage, debt bondage, and slavery. All of these have long, specific legal definitions that I'm not going to get into now. But what I want to point out is that there is no single fact or no single criminal moment that characterizes labor trafficking. And this is another reason why most of our responses to human trafficking are characteristic of or reactive to sex trafficking specifically, because sex trafficking does have this component of a commercial sex act, some forced sexual violence that is easy for us to root our response in and to reference and point to when we're trying to identify that there is a crime here that needs to be addressed. However, labor trafficking has no such, easily identifiable single criminal instance. Instead, it is the amalgamation of a series of negative, abusive workplace situations that together, following this pattern, raise the situation above just workplace exploitation into labor trafficking. Because most of our responses to human trafficking actually address sex trafficking, as I said, labor trafficking is often left to the side, and this has a few important consequences. If you could go to the next slide, please. First off, most of our responses to human trafficking focus on screenings and resources that target women and children. Again, because the perception that women and children tend to be victims of sex trafficking, and most of the times our responses to human trafficking are responses to sex trafficking, most resources out there are geared towards women and children. This is especially problematic in the context of labor trafficking because in many industries, such as agriculture, construction, landscaping, the vast majority of victims are male and are oftentimes being left out of support systems or screening processes. Secondly, this overemphasization of sex trafficking vis-a-vis labor trafficking means that many of our screening tools or the paradigms we use to identify human trafficking focus and prioritize things such as domestic violence or easily recognizable sexual exploitation crimes. Again, sex trafficking has this sexual violence component that we can root our reaction to and our response to, and that leaves out many of the fact patterns that characterize labor trafficking from most of our screening tools that are supposed to address all types of human trafficking. Another bias that I often encounter with labor trafficking is that if you use some of the other synonyms for labor trafficking, such as modern slavery, people tend to imagine them as happening in this like sensationalized criminal underworld or far away. When I say modern slavery, you're probably thinking of, workers in coal mine or diamond mine in Africa, or indigenous workers in a coal mine in South America. And this implies that this is something that happens far away, not near me, and not something that I have to worry about in my day-to-day as a medical service provider. However, the reality is very different, and labor trafficking does occur in Pennsylvania. It does occur in the places where we live, and envisioning it as this movie-esque crime that only happens far away means that oftentimes we aren't including labor trafficking in our screening and response tools. Lastly, by focusing on sex trafficking, human trafficking toolkits often ignore occupational health risk factors that labor trafficking survivors face. Many of the industries where labor trafficking occurs are more prone to injuries, such as construction or agriculture. And because of the exploitative nature of the trafficking employment, victims are even more likely to be exposed to some kind of workplace hazard. And that often is left out of the conversation when we're talking about medical responses to human trafficking and where resources are being invested in terms of research. So now that we've talked about what labor trafficking is not, how it's distinct from sex trafficking, and that it is often left out of our response tools, I want to hone us back in to what labor trafficking is in practice and what it looks like in Pennsylvania specifically, which is where we're based out of. First of all, labor trafficking can occur across industries. At Justice at Work, the bulk of our clients are employed in industries such as landscaping, agriculture, hospitality, and restaurants. And again, because labor trafficking is not defined by any set combination of facts, the mechanisms and the schemes that traffickers use can vary widely from industry to industry and can require a high level of expertise to identify and pull out. Secondly, labor trafficking occurs very frequently and in many places. In Pennsylvania, for example, just since 2017, Justice at Work has represented survivors from over 26 of Pennsylvania's 67 counties. And our clients live in places such as the population hubs on the eastern and western parts of the state, as well as some of the more agricultural and rural counties in the middle and northern parts of the state. Truly across the board, this is happening in Pennsylvania. And unlike the idea of human trafficking that we tend to see in movies, in practice, labor trafficking individuals, especially in the United States broadly and Pennsylvania specifically, we've seen often have a large amount of agency and are able to move. And the inability to leave their workplace is not as frequent as you would think. And so lots of these survivors are interacting with lots of our social systems, with lots of our medical systems. And this provides an opportunity for medical service providers to serve as a link to help survivors connect with resources to escape or recover from their trafficking experiences. Just to offer a few more concrete examples of what our clients tend to look like, labor trafficking could look like an immigrant worker who lives in employer-provided housing above a restaurant, making far below minimum wage and discouraged from making outside friendships by their employer. The employer can leverage the dependence that this person has on their housing that's tied to their employment and the lack of a support network to exploit them to a very severe degree. And this can happen, this person can end up in a labor trafficking situation, even if this restaurant and the place where they live is in the middle of a large city, for example, in Pennsylvania. A labor trafficked individual could also be, say, an immigrant worker who comes legally to the United States through one of the employment-based visa programs. I have an example here, the H-2A visa for agricultural workers. Because this person lives and works on a farm in a rural part of the state, they're isolated, and this leads to a lack of access to resources that could help him address issues that come up over his employment, such as stolen wages, discrimination, or the inability or lack of permission to leave the farm. And again, none of these workplace abuses individually constitute labor trafficking, but together in the pattern I described above, they could raise the abusive situation to the point that this person is considered a survivor of labor trafficking. And last example I have is a landscape worker who is intimidated to continue to work despite stolen wages, extremely long work hours, and is constantly subject to immigration threats. Even though this person might live in a large urban area, and be in constant contact with other people. They go to the supermarket, maybe they go to doctor's appointments. The possibility of being deported based on the immigration threats that their employer is giving them if they try to leave the job could be enough to keep them trapped in this abusive labor trafficking employment situation for an extended period of time, even if they are interacting with a number of resource systems, if those resource systems don't identify this person as needing help. The last thing I wanted to say about the realities of labor trafficking and what it looks like in practice before I hand it off to Hanni is to acknowledge that while many immigrants are brought into the country illegally to be trafficked, both sex and labor trafficking can and do occur to US citizens as well. Labor trafficking happens to both people who are brought into the country illegally. It can oftentimes be a part of the process of bringing them into the country illegally, but it can also happen to US citizens that get tricked and manipulated or forced into some of these abusive situations. I also want to point out that immigrants may be trafficked despite having legal immigration status. At Justice at Work, we have lots of examples of clients where their trafficking scheme, their employers actually manipulated employment-based visas and exploited those visas to facilitate them to bring people into the country for labor trafficking. And we have a large percentage of our clients that were in the United States legally and over the entire course of their trafficking. In other words, their entire trafficking experience happened entirely within the legal US immigration system. Justice at Work specifically serves mostly immigrant clients. So this presentation and the content that Hanni is going to share focuses on labor trafficking among immigrant and migrant communities specifically. So I just wanted to put that caveat out there as we go into the rest of the content of this presentation, that this is specific to immigrant and migrant communities in Pennsylvania, but I wanted to make sure to acknowledge that labor trafficking and sex trafficking can occur to US citizens as well, as you all go through your work. And with that, I'll pass it on to Hanni.
Awesome. Thanks so much, Phil. And I realized I didn't talk a ton about HEAL at the top, so I just very briefly, we are an international organization, now have folks in 45 countries around the globe that are part of our network. We operate by creating community, so we have an online community and share resources with each other through that mechanism, and then are very invested in education and training and technical assistance that helps build capacity of health systems. So at a structural level to respond to trafficking, as well as building capacity of those with lived experience and health professionals to train others to respond to trafficking. And just, again, super excited for this opportunity to share with all of you, because I really see this as part of undoing a lot of the inequities that have been laid down in the anti-trafficking space in the United States. And we're hopeful that this information sparks further work, further research, and further action. So, and I answered a question in the chat thing, and I think that makes it public for everyone to see, but please continue throwing those questions, and we'll monitor the chat, and we can answer stuff live too, as that makes sense. So this is all about the study here. I'm going to start presenting some of the data, and just to kick us off, just to give you a sense of what our data set looked like. So we were analyzing 114 cases of immigration files of labor trafficked individuals. The time period was about a decade, so over the course of 10 years. And our approach was one where I, as the clinician lens, was advising externally, and those from JAW were looking directly at the case files. And the information that we extracted were information about demographics, and we'll share what we included when we mean demographics, workplace or those occupational exposures, health outcomes, and healthcare utilization patterns. Now, really important to note here is that the data was not collected for this analysis, right? This is data that was collected as part of providing services through for the immigration services through this legal aid organization, JAW. So there's a lot of information that may a lot of health experiences, a lot of workplace exposures that may have occurred that were just not part of the conversation or are relevant to include for that case file. So there's all of those limitations. And yet, despite that, there's a treasure trove of healthcare and occupational health related information that we're going to share here. And this is important as you're hearing what the findings are, the demographics of those 114 case files. So the lion's share were subjects from Mexico, and most of the entire cohort were from Latin America. 82% were male. The mean age was 30 years old. And 25% had immigration status during all of their trafficking experience. So Phil had mentioned H-2A visas. So these are folks that came here, 25% were here on a visa or an immigration status of some sort. And then that means that the remainder, 75%, did not have immigration status while they're being trafficked. Other demographic information, as we look at the sectors that they were trafficked into, some folks were working in more than one industry. The lion's share of this data set were working in landscaping, and followed by agriculture, domestic servitude, restaurant, cleaning, construction, hospitality. So as I look at this, I promised I was going to sort of sprinkle in some of the clinical piece. One of the things that's really important to me in my clinical practice is to ask my patients about the work that they do. Because we absolutely know that there are some industries that are more high risk for trafficking. And when you combine a bunch of vulnerabilities and an industry that's rife with trafficking, those are patients that I want to have a trafficking assessment conversation with. Another interesting demographic finding was that in the course of the conversation of receiving their services, half of them mentioned that there's a sick family member prior to or during the trafficking situation. And as I look at that, one of the things that I think about is the high cost of healthcare and how those financial debts related to healthcare provision, whether for oneself, but also very compellingly, if it's one of your family members, if it's a sick loved one, how that can keep you in a very dangerous exploitative situation farther along than you would if it was maybe even for your own health. Also, in terms of demographics, so 97% had limited English proficiency. I can't tell you how many times my residents will be like, oh, can we just have the family member interpret or this or that? It is absolutely imperative in our clinical practice to always use an official interpreter. We know from other trafficking research that person that may accompany a patient, a trafficked patient, may have the same age, same gender, same ethnicity. They may actually be another trafficking victim that's sort of there for eyes and ears for the trafficker. And so just to recognize that language barrier should not be there. That should not be the reason that somebody ends up not getting the care that they need from healthcare. U.S. citizen children during trafficking. So this was also very, very high. And so why do we mention if their kids were U.S. citizens? And the reason is that means that they most likely had multiple interfaces with other systems, other social support systems. So those children may have an ESL teacher. They may be accessing a pediatrician. Their spouses that then get pregnant and have children may be interfacing with OBGYN. And so there can be a range of interactions that occur for not just the trafficking victim, but their family members. And this is something that I've never seen in the literature previously. Phil, I don't know if there's anything else you want to add here.
Just briefly to address the fact that lots of these, as Hanni alluded to, these are not just U.S. citizen children. Sorry, let me take a step back. This U.S. citizen children means that they had a child under the age of 18 at some point during their trafficking experience, and we had a number. We didn't pull this out to this level of detail, but I can tell you anecdotally, lots of these U.S. citizen children were very young, under the age of 12, lots of them under the age of 5. Some of them were born over the course of their trafficking experiences. To just highlight, for example, if a child is born, that involves a series of different visits to OBGYN appointments, hospital stays. And then for lots of these small children, the bulk of them will be eligible for some type of medical insurance. And so just to highlight just how many other ways these families are interfacing with, the extent to which they're interfacing with their medical system, that these individuals aren't existing in some vacuum.
Thank you, Phil. So we talked about the fact that occupational health exposures are often not in some of the traditional list of red flags for trafficking victims, or included in screening tools for trafficking. And this is really an important gap to identify. And this information helps to give us a little bit more information about why that's relevant. So we saw that 19% had exposure to chemicals or hazardous materials without personal protective equipment. 28% were in unprotected exposure to unsanitary or insufficient living conditions. 36% had exposure to extreme temperatures. And as it related to workplace injuries, there were 112 reported injury events, and 19% of the subjects reported 2 or more. Phil, anything else on this that you wanted to mention? Kind of like a range of the.
Yeah, I just wanted to highlight a few of the limitations of it. It's really cool that we have this multidisciplinary approach to accessing the data, but one of the limitations is that since these were, as Hanni already alluded to, this information was collected in preparation for immigration applications, not as part of a doctor's visit. So lots of the information, for example, about injury events was qualitative. So we had lots of instances of someone saying, oh, I was hurt several times at work, or I remember getting cut several times, a couple times in the kitchen. So when we were extracting the data, we coded all of these the most conservatively we could. So if someone said, I got hurt at I remember cutting myself and injuring myself at work several times, that was coded at 2, because it implies more than 1, but we don't know how many more. And some of these might not have even come up, right? Like exposure to chemicals or hazardous materials without PPE. A legal advocate is only going to ask it if it is relevant to the trafficking narrative. Otherwise, because of trauma-informed practices, we're not going to pry for things that might be traumatic for subjects to remember. And also, we're, as legal advocates, we're not necessarily interested in some of these finer details about their medical history. So I would just like to point out that all of these I would consider strong lower estimates, the most conservative estimates out there. And then for the injury events, it was because of the qualitative nature of how they described these injuries, it was hard to code the severity of them, but they range from scratches and cuts like in the kitchen to being temporarily blinded in the eye with chili oil from a kitchen incident, or getting a metal rod pinned through a leg and being stuck to the ground for 6 hours while someone called an ambulance for them, or near amputation from workplace injuries. So just to give an idea of the range of injury events we're talking about.
So this finding about sleep is also really fascinating. Again, to underline, these are the tip of the iceberg, right? There's so much more that was happening for these individuals. And so the fact that it ended up in here means that it really is the tip of the iceberg in terms of the sample. But so as someone who thinks a lot about my patients' mental health, we know the effects of trauma and stress lead to sleep deprivation from insomnia or nightmares. And that's been described in the trafficking literature. But what we also saw was that was compounded in this sample by being forced to work long hours, which totally does make sense. But the combination of the two can really make someone delirious, essentially. And so this was something that they noted that it was impacting their health and their life. And then also being forced to work while injured. So as I'm thinking again about like what direction do we have for future study, knowing that if I'm taking care of a patient that have a high concern for an experience of abuse, violence, or neglect, including trafficking, asking questions around being forced to work while injured. This was a really high percentage, 71%. And then Phil, do you have anything else to add here about sleep?
Just to expand a little bit on what Hanni alluded to with how it can affect not only people's health, but mental state. The sleep deprivation was so intense, and I'll talk about this again in some of the case studies later, that several of our clients identified on their own that they were so sleep deprived and it was affecting they describing in this haze and not being able to think straight, that they linked that to being trapped in their trafficking situation. They would say things like, I was just so tired and exhausted and mind numb that I couldn't even think, like fathom about looking for another job or standing up to my employer, or that effect. Another thing that we've seen in some of these claim files is subjects describing the situation as, because I, was so mentally just in a haze, it was hard for me. I've seen the phrase, like, I don't know how to describe it other than it was hard for me. And it took a while to understand just how negative the situation I was in and just how abusive it was and how badly I needed to escape from it. And they attribute part of that process not only to, some of the other barriers they face, language barriers, immigration barriers, not knowing their rights in the United States, labor rights, but also to the fact that they were just so sleep deprived and walking through this mental haze that it was also affecting their ability to reason through why they needed help effectively.
Thank you, Phil. It actually reminds me of there is a study where someone compared to some of the tactics that traffickers use to what torturers in prison for prisoners of war use, and how similar those tactics are. And that's something that comes to mind as we think about it's very strategic, right? That it's not just the fact that they're trying to get tons of work out of them, but also it's actually strategic towards their ends of keeping them trapped. So I was very interested in the question of, we know that these folks are trapped in they are not able to leave this situation because of forced fraud and coercion or coercion. And there was one study that was done in the United States, which with a much smaller sample size of labor trafficking survivors, that just asked the question, did you interface with healthcare? And so this question has not really been looked at since that time. I think that was like 2013 or so. And so I was really curious with this cohort, how many times they actually had a touch point with formal healthcare. We do know that from other studies, we know that traffickers will sometimes just basically send somebody to like their friend who's a clinician, or, not actual formal healthcare settings. And so this was an important question for me to know the answer to. And we saw that altogether, 38% of the subjects did report interacting with medical service providers at least once during their trafficking experience. And for some of them, it was definitely more than once. What was also interesting is that was actually despite the fact that employers interfered in some way with that access to medical care in 100% of injury events where care was accessed. And so just again, going back to that, should we be asking patients that come in a workplace injury, was your employer trying to prevent you from coming to the hospital or to the clinic? I think is a really important question to explore. And 28% of them accessed medical care for injury events. 58% of subjects developed some type of medical condition over the course of their trafficking, with 97 medical conditions reported. And for those medical conditions, so these are the non-injury, able to access medical care to address 24% of these conditions. So further, under healthcare utilization patterns, so that next question is where were they accessing this care, and what did they mention again in the course of receiving services for their immigration case? And the locations were primarily hospital. There were a couple instances of clinics and private practice, but really the lion's share were accessing hospitals. And we mentioned this earlier, but 43% of subjects had U.S. citizen children. And so we're mentioning again here, just to think, in addition to the contact with schools and other social service systems, because 43% of subjects had U.S. citizen children, there was likely some interface, either the spouse of the trafficking victim interfacing with healthcare and or the children themselves. So as we go into these case studies, these are fabricated studies based on themes that we saw from the data. And I encourage you, from all of the various professional lenses that you carry in this group, I encourage you to think, as Phil is talking through these cases, about individuals that you've interacted with that might match some of these profiles, and think about how, as we're talking here, how seeing these cases may change the way that you approach these individuals. So Phil, over to you.
Thank you. And I know we're running a little bit behind on time, so if we could move the slide ahead to case study 2, that would be great. So this case study is about Sonia. Sonia is being trafficked at a restaurant. She works 12 hours a day, 6 days a week, and makes a couple $100 every 2 weeks or so as her pay period. She's married and has 2 small children. Sonia has been injured on the job several times before, involving small cuts from working in the kitchen or slips and falls, but has never told her employer because he's very angry and will often yell and throw things in reaction to other people asking for help or getting injured. So she's been afraid to speak up when she's been injured in the past. One day, Sonia spills hot soup she was preparing on herself, severely burning her lower leg and foot. She asks someone to call an ambulance, but her employer forbids Sonia's coworker from helping her, saying that he, quote, doesn't want any problems. Despite Sonia repeatedly begging for immediate medical attention, her employer refuses. Several hours later, after completing her shift, working through the pain, and after taking a moment to sit down, Sonia was in so much pain that she still decided to go to the ER despite her employer's threats. After receiving treatment, later that evening, Sonia received a text message from her employer asking if she is coming in the next day and implying that she could lose her job if she did not. Because of this, Sonia was forced to work throughout her painful recovery period. If you go to the next slide, I've highlighted a few things about Sonia's case study that I think are important to highlight. First, as Hanni touched on, lots of these clients are working a very, very long hours. Sonia's working 12 hours a day, 6 days a week, and it's definitely not being paid appropriately. And then this is also a good example of both the implicit and explicit ways employers and traffickers will interfere with the subject's access to medical care. So you have this implicit interference where he has reacted negatively to other people being injured in the past and has this pattern of aggressive behavior that makes her fearful of reporting medical accidents in the past. And then you have this explicit one later on where he explicitly tells her coworkers that they cannot call an ambulance to help Sonia. The interaction of these two is something that we see very frequently in our cases where clients will report injuries, but they say because of how he's reacted to other people or because of threats he's made to me in the past, I've been afraid to speak up in these smaller instances and will be forced to, but will find themselves speaking up oftentimes in the most egregious. The injuries are so intense that they feel the need to speak up, even though they're afraid of the possible retributions. Here, Sonia goes to the ER and receives treatment. However, despite this prolonged interaction with ER staff, no one identifies her as potentially suffering workplace abuses and nobody connects her to other resources. From this, we're not entirely sure if it's because of there isn't proper screening tools or Sonia doesn't speak English. Maybe there was something to do with the language barrier. But this is an example that we see a lot of the types of formal interactions that clients have with healthcare professionals, where it's often happening in the context of an ER visit, and then they're being given follow-up appointments. Like Sonia was probably given a follow-up appointments, but was not able to go to it because their employers do not let them take off time, or might continue to threaten them if they allude to the fact that they need continued treatment. And as Hanni pointed out, you can see here that Sonia was forced to work through her painful recovery on her foot. This is something we see very frequently among our clients. Next case study, please. This one's about Jose. Jose is being trafficked at a construction job. He's married and has 2 children who are both US citizen children, and his wife is currently pregnant with their 3rd child. One day while on the job, a sheet of metal slips and slashes Jose in the leg, resulting in a deep cut. Jose tells the supervisors that he needs immediate medical attention, but the supervisor tells him to wait for the employer, who is not on this specific work site, to give further instructions. Once the employer finally arrives, he offers to take Jose to the hospital, but first instructs him to take off his work boots and company shirt and warns him not to tell the doctor how he got the injury or where it happened. The employer also offers his veiled threat to Jose and tells him that he should, quote, think about his wife and children, end quote, and what they would do if he was deported. Instead of the hospital, Jose's employer actually takes him to an urgent care facility, where Jose was immediately sent to the ER because of the severity of his injury. Once there, the employer spoke on Jose's behalf because Jose did not speak any, this is a typo, should say English. He speaks only Spanish and does not speak any English. Since the employer immediately steps in to serve as his interpreter, the hospital staff never once speak directly to Jose and instead use the employer as an interpreter. Only later, when Jose ends up with some unexpected medical bills and does some follow-up to figure out why he's getting them, because he was told he wouldn't have to pay for this by his employer. He realizes that the employer had told hospital staff that he was Jose's, quote, family friend. Jose ends up having to cover all the costs associated with this visit to the hospital, was only given 1 week off to recover, which was not paid, was forced to come back to work despite the fact that he was told to rest for more time, and was never able to go back to the follow-up appointments that his doctors made for him because of some types of interference from the employer. Things we tend to see include explicit threats or discouraging, saying like, they just want your money anyways. You don't need that. I'll help you. I'll pay for it. And then refusing to do so. So if you go to the next slide, there's a few things that I wanted to highlight. First is that Jose has US citizen children and his wife is currently pregnant. And as we alluded to previously, this means that Jose, in the preceding months, at least his wife has probably been going to several OBGYN appointments. His kids have probably been going to pediatrician appointments over the past few years. And so even if he is not able to go to those doctor's visits, potentially because his employer doesn't let him take off work, his family is interfacing with a significant number of medical healthcare systems that are not identifying the family as needing resources, or identifying his wife and their kids as second-degree victims of this workplace exploitation. I also wanted to point out that Jose is being trafficked at a construction job, and that this is most likely happening in an urban center. His children are going to school. They probably live in a city. This is happening in this is not happening far away or in complete isolation. In his time off, Jose is probably taking his kids to soccer practice and going to the supermarket to get groceries. He is interacting with a ton of the systems that are in place and interacting with members of the community, and no one is identifying the severity of the workplace exploitation he's suffering. The situation that we see with Jose when in the immediate aftermath of his injury is something that is a common trend among many of our clients, where instead of immediately accessing medical care, they are forced to wait basically for the employer to triage whether they deem the situation bad enough that they want to risk exposure for the company because of the workplace injury. Oftentimes we've gotten reports of clients waiting several hours for an employer to make it to the work site, despite intense pain, severe loss of blood, and very, very significant injuries. Despite the intensity of his injury, he's still forced to change his clothes to minimize the exposure that the company might have to being identified as being responsible for his injury. And this is an interesting one that we noticed a few times coming up in these narratives, where employers will first take people to urgent care facilities. I'm not a medical professional, but the inference here is that there's less systems there to identify potentially that these are workplace-related injuries and to put the cost on the employer for recovery. And is only referred to the ER when the urgent care is like, no, this is bad, you need to go to the ER. And then the most egregious part of this, I think, is here at the end, where the lack of a language access plan at this hospital means that Jose's employer gets untold access to not only the narrative of the injury that he suffers, but the kinds of resources that he's able to connect to and the fact that he's not identified as needing extra support. So hopefully these are just a few examples that help ground your perception of what labor trafficking looks like in some of the places that we live and what these patients might look like when they interact with our medical systems.
So as we've been going throughout, I've been giving some of my recommendations. There are definitely lots of areas for further study, including thinking about sick family members, thinking about interference with accessing healthcare, working while injured, and understanding those healthcare intersections with the U.S. citizen children of those who experience trafficking. For the health professionals in the room, I think the first step is really just start thinking about labor trafficking. Some of you might have a variety of expertise as it relates to trafficking and be at expert level versus just learning, but inform yourself, be curious. I'm going to put 3 links in the chat for you. HEAL's website has a plethora of resources for you. One thing that I just want to flag that is counterintuitive and has been a learning curve for me is that when I was trained as a medical doctor, Harvard emergency medicine physician, I thought that screening for violence was asking questions and doing a checklist. And as I listen to survivors and look at the research, really look at the research on other forms of abuse and violence, what I learned is that it's more important how you set up that conversation and how you make somebody feel than it is the actual words that come out of your mouth. And we've all experienced this, right? Like if you feel checklisted, why would you share this thing that you have so much fear about? So there's so much stigma, you might even have self-judgment about. And so you really have to feel like you can trust the person in front of you. So the tool that we recommend is the PAIR tool. P stands for privacy, E for educate, A for ask, R for respect and respond. And there's a point where you do ask questions, but it's customized to that person's experience. And the provide privacy is also includes using a professional interpreter. Sample questions. These are also available on our website, but there are some screening tools that are out there that are validated that incorporate labor and sex trafficking. And when you're trying, everything in medicine is a practice. When you're practicing how to ask these questions, I think is really helpful to use these tools, but then customize the conversation to the patient.
As Hanni said, the use of interpreters is super important to creating a private and safe space for victims to share their experiences with you. And the last thing we just wanted to throw out there, of course, is be up to date on specialized referral options. You, as all as medical providers, have a ton of things already going through your minds. So we aren't expecting you to get good enough at this to identify labor trafficking. That is very hard to do, but to know some of the things that you can refer potential patients to get the specialized screening and resources that they need. So if you go to the next slide, I just threw some of the basic ones up there. National Human Trafficking Hotline is a resource for both advocates and people who are reporting things they've seen, as well as victims to call in and get support. At Justice at Work, we've received several clients who have been connected to us through the National Human Trafficking Hotline. And then Framework TA is a tool that was funded by the DOJ that includes lots of resources for providers as they seek to better support survivors of labor trafficking. And of course, you can always reach out to us at Justice at Work and HEAL. We're happy to provide more information about this topic. And both of our organizations do a number of different trainings about labor trafficking, human trafficking more broadly, and how to better identify and screen for labor trafficking in a medical context. So our contact information is up there. And that brings us to the end of what we had to talk with you all about today.
So both of you stayed on top of all of the questions. I'm just going to wait a couple of minutes if anyone else has a question to throw into the Q&A to ask. I learned so much from both of you this evening, and I also learned that there's so much intersection in the way that whether you're working with a victim of sex trafficking or a victim of labor trafficking, how to approach the so-called screening checklist, right? I practice law, you practice medicine, and we approach with, some things in the back of our mind, but we tailor the way we speak with our clients and the questions that we ask to solve their legal problem, like you're solving a medical problem, to the client sitting in front of us, just like you do to the patient. So I love the College of Physicians, specifically the section on public health, for letting us do this tonight. And again, it just really showcases how interdisciplinary work pushes public health, healthcare systems forward by working with other professionals like Phil, who is at Justice at Work, and me, who's at the Institute to Address Commercial Sexual Exploitation. I have one quick question here. Let's see, one popped in. This is a great question. What does it look like for the healthcare team to successfully connect a patient survivor to legal services? And how long might it take a survivor to get out of their trafficking situations? And do you have any case examples?
I will just say here that, and this is something the survivor told me, my job is to plant a seed. My job is to provide resources and connect. My job is not to control all of the things that happen after I plant that seed. My job is to create that open door. And it may take someone connecting with various resources 50 times, but you don't know where you're on in that person's journey as a caring professional. You might be the first person that's planting that seed. You might be the 25th, the 49th, the 50th. Your job is to be that caring professional that educates and empowers them with information and resources. So, Phil.
Yeah, and how that relates also to healthcare specifically. A common thread we've seen throughout several client cases is actually how injury events can help be that last thing that triggers someone to be like, no, that I have to get out of this situation. Like either how negative the injury is or the employer's negative reaction has sometimes been that moment for people of like this, I have to get out of here. I read the line or I'm going to die, or something is going to happen to me someday. And so it's interesting how that can relate to healthcare as well. In terms of how long it can take someone to leave a trafficking situation, the subjects, the 114 subjects, the amount of time they spent in trafficking ranges from a few months to a few decades. It really, because trafficking situations can vary so much, it just really depends. And it also depends how long it takes them, even once they've decided they're trying to leave. There's so many things that go into how a person exits a trafficking situation. You have housing to consider lots of times. You have economic stability. You have even mental health. We refer lots of clients to rent mental health services and have some partnerships with mental health providers, because oftentimes clients are in such a state of trauma that they aren't able to make those hard decisions to get out of the trafficking experience. And so there's just so many pieces at play here because of how all-encompassing labor trafficking is, and how it just involves not only the job, but also so many psychological and physical negative effects that just really impact how each person reacts to it.
And feel like if you inserted sex trafficking into your answer, it's the same, right? Some of our clients were trafficked once or twice, and some for decades. So, and the same needs that they have to exit, I mean, it's the same thing. It's safe and stable housing, it's economic income, it's all of those things. Again, I want
to
go ahead.
add to this in 1 second. Something that I find surprises people lots of times is when we tell them that we have lots of clients who they're coming on these temporary visas, for example, that involves them entering the country at the beginning of a planting season and leaving at the end. And we have lots of clients that come back to employment, trafficking employment, year after year, just to speak to like the intensity of some of these manipulative effects and how desperate some people are for jobs oftentimes, that they continue to participate in this process of signing up for a job, coming to the States, going back to their home country, coming to, and even though it's extremely abusive, because of just how deeply some of these traumas and manipulation schemes run. That was it. Sorry, Shea, jump on you.
No, I just wanted to say I am so grateful for the two of you taking the time to, speak to your expertise. When is or how can we access your research? Are you publishing a paper? Where can we look for this?
So we are in a revise and resubmit stage with the journal. So those of you who do peer reviewed, so we're hoping soon. So we just resubmitted. So maybe we'll just get a magical email as soon as this is over. We can all send
I know the process as well. Yeah. So this is great. You are working with the publication. For everyone here, as soon as you get that, will you let me know so I can disseminate the information out through the college? Because I think it's just so valuable.
Absolutely.
Thank you. I just want to thank the College of Physicians, specifically the section on public health, for letting us use their platform tonight. And for anyone who has any questions, you can always reach out to me. I can connect you with both of our panelists this evening. And thank you all for listening and for participating and being with us this evening.